Welcome back, Chapter 17. This is going to be Lecture 4, Cardiovascular Emergencies. We're going to pick up at slide number 151. We're going to be covering PEA and cardiopulmonary arrest and the algorithms that are involved with that. So PEA, pulseless electrical activity. That's what we're going to start with first, but I need the slide set. Okay. There we go. PEA, pulseless electrical activity. All this really means is that we have a rhythm that's being generated through the heart itself from the SA node, AV node, or down in the bundles depending on its rate. And it's just not producing a mechanical capture. Otherwise, you do not have any pumping of blood. All you have is an electrical impulse. So, with that said, why do we have this? It's organized. It's an organized cardiac rhythm, but again, it doesn't have a detectable pulse. The mechanical ventricular portion of it isn't happening, period. It's too weak to produce a palpable pulse. Usually these are in cases of the patient that's in cardiogenic or hypovolemic shock. That's one instance. Something has gone wrong with the heart, or somebody has lost a lot of blood. So now that there's not enough blood to keep the heart primed or pressurized, all you have is an electrical impulse, but there's not enough prime in there to make the heart beat. Another cause could be cardiac tamponade. Could also be massive pulmonary embolism. You could also have electrolyte disturbances to include hyperkalemia in the case of a patient that may be in renal failure. And then potentiality of patients that have a drug overdose. The key to the treatment of patients that have PEA is to treat the underlying cause. You got to find out what's wrong with it. So therefore, we work with what we call the H's and T's. PEA is a non-shockable cardiac arrest rhythm. There's nothing you can do about it. But the H's and T's are very important. We're going to discuss those now. I'll outline them on the board here. The H's to begin with. The number one is hypoxia. What is hypoxia? Hypoxia is when we have inadequate oxygenation to the blood. Okay? There's not enough oxygen in there, so the patient is hypoxic. Next one is going to be hydrogen ion acidosis. So the patient is acidotic. They've got some kind of condition that's going on that the patient has become acidotic. They have a pH that's less than 7.35. Okay, so they're acidotic. Next one could be a patient who is hypovolemic. They've lost all their blood. Okay, they don't have any more blood. Next one that needs to be ruled out is hypokalemia. They have a potassium ion deficiency. Okay? Something has gone wrong with their potassium system, and we find this a lot with our renal failure patients. Hypocalcemia. C-A-L-C-E-M-I-A. They have a deficiency in calcium, which affects their sodium-potassium pump because you don't have a calcium ion to off-balance the negative ions the positive ions from the sodium. So hypocalcemia. There's one more that's on here that people tend to forget. It involves sugar. Hypoglycemia. Those are your H's. So if we're working with a patient and they're in PEA, we need to rule out the H's. These are the H's. These are the ones that we're going to look for first. Okay? The number one that we find in most cases is hypoxia. Number two, hypovolemia. Number three, hydrogen ion acidosis. The hypokalemia, hypocalcemia, and the hypoglycemia, those are for specific types of patients. Diabetic patients, renal patients, Patients that take potassium supplements that overweigh the amount of calcium that they have in their bloodstream, those kind of things. So, those are your H's. Now let's talk about the T's. First one, tamponade. Cardiac tamponade. This is when something's happened to the chest, okay, and caused the myocardium, specifically the pericardial sac, filling with blood and surrounding the myocardium, and therefore putting pressure onto the heart itself and causing a situation where the heart cannot adequately fill. All right. Next one, tension pneumothorax. Tension pneumothorax can cause your PEAs or cardiac arrest. When we're looking for our T's, that's what we're looking for. Collapsed lung, there's air inside the chest, whatever the case may be, and you have a tension pneumothorax. And ultimately, it's causing the hypoxia. Next one, toxic. Some kind of toxidrome. Something's in there. You've got an overdose of medication, you got chemicals, you got something that's causing a toxidrome that's creating a situation where the patient cannot regain mechanical capture. They're in PEA or VFib or asystole. Either way, they're in cardiac arrest. We've got to resolve it. Trauma. And then finally, trauma is obvious. And finally, thrombosis. This is most common. Either cardiac or pulmonary. It originated into the body somewhere, like a clot, a thrombosis. It ended up in the heart, in the right side, blocked the pulmonary arteries, so now you can't oxygenate. Okay? Or it stemmed from a cardiac clot and it's gone to the brain or somewhere else, which it caused cardiac arrest. So pulmonary or cardiac is our problem. Okay? Those are most common with thrombosis. So those T's, once again, tamponade, tension pneumothorax, toxidrome, trauma, and then thrombosis to include both pulmonary and cardiac. And the key to the treatment of these patients is to find whatever the problem is and eliminate it. Some things we can do something about, some things we cannot. Ultimately, patients in cardiac arrest, they need to be managed in appropriate ways. The number one thing that I want you guys to remember is to go back to your basics. High quality CPR. Without high quality CPR, your patient's going to die, or your patient's going to have a bad neurological outcome. Most patients with cardiac arrest have some kind of evidence of prior heart disease. But it can also occur from electrocution, drowning, trauma, drug overdose, asthma, anaphylaxis, and possibly no warning prior to the event. Cardiac arrest management requires an orderly, systematic approach that's rehearsed repeatedly over and over again in a team setting. Bring the following devices and equipment when you initially approach the scene: your defibrillator, portable oxygen cylinder, airway management equipment including an intubation kit, IV equipment, and a drug box. Those are your minimums. Those need to be on your stretcher when you go in. The goals of emergency medical care of a patient in cardiac arrest include return of spontaneous circulation. Do put the name or the acronym ROSC, R-O-S-C, in your brain. You're going to hear this a lot, a whole lot. And also the preservation of neurological function. The way we preserve neurological function is to do good cardiac arrest management. We do good CPR, good oxygenation, to ensure that we oxygenate the brain to keep it from dying, so we have good neurological outcomes. Begin emergency medical care immediately upon discovering the patient's pulseless. Withholding CPR is a consideration appropriate when the following: attempts to perform CPR would place the rescuers at risk. there are obvious clinical signs of irreversible death or injuries that are incompatible with life, a valid advance directive or a physician's order for life-sustaining treatment form indicating that resuscitation is not desired, otherwise known as a DNRO. And that needs to be original, it needs to be signed, and it needs to be there with the patient. Proceed with CPR as follows. If bystanders have delivered uninterrupted chest compressions before your arrival or the rest is witnessed by EMS personnel, proceed with the rhythm analysis. Find out what your rhythm is. If compressions have not been provided or the arrest has not witnessed by EMS personnel, be sure to start chest compressions while a second rescuer sets up the AED or defibrillator to proceed with rhythm analysis. The components of high-quality CPR include the following: chest compressions at a rate of 100 to 120 per minute. A compression of the chest to a depth of at least 2 inches. Full chest recoil after each compression. Minimal interruptions of compressions. And adequate ventilations to include 2 breaths after 30 compressions. Alright, so there's 4 possible cardiac arrest rhythms: pulseless V-tach, pulseless V-fib, asystole, and PEA. Key points to remember: if defibrillation is indicated, then the provider giving chest compressions should continue while a second rescuer charges the defibrillator. Then pause CPR, clear the patient, and deliver the shock. You need to make sure we're clearing the patient. You don't want to inadvertently cause the defibrillation of one of your teammates. Resume chest compressions immediately without pausing for a rhythm or a check. Be sure to put this in your brain. Defibrillate the dead, cardiovert the living. If you'll remember that premise, you'll remember that the only people that we defibrillate do not have a pulse. The people that we cardiovert are still living. We're just trying to change the rhythm to a more viable rhythm for the patient. After 2 minutes or 5 cycles of CPR, pause resuscitation efforts and check the rhythm on the monitor. Please ensure that you're doing 2 minutes of high quality CPR. After every drug, after every defibrillation, every sequence revolves around 2 minutes of high quality CPR. If a rhythm other than VFib or VTAC appears, then identify the new rhythm and check for a pulse. If there's no pulse, then move down the algorithm to the asystole PEA pathway and immediately resume CPR. If there is a pulse, then move to the appropriate algorithm for the new rhythm. If the rhythm is VFib or VTAC, then resume CPR while charging the defibrillator. Always when the defibrillator is charging, take the opportunity to continue CPR while it's charging. Clear the patient and then defibrillate. Minimize rescuer fatigue by switching CPR compressor and ventilators at the end of each 2-minute session of CPR. If you have enough people, the people that are switching from CPR to defibrillator are those 2 people. The guy that's operating your defibrillator and the guy that's doing the CPR will switch. The person on the airway will stay there. To maximize the number of compressions delivered per minute, interruptions of in any regard should not exceed 10 seconds. So we only pause CPR for no more than 10 seconds, period. There's no excuse to do it any other way. So if you have somebody that says, no, don't do CPR, I'm trying to intubate, tough. You're going to have to learn to intubate while somebody's doing chest compressions. Plain and simple. Use the normal saline, attempt to establish vascular access. If you're unable to establish IV access, then establish interosseous access using an adult IO system. Vascular access should be achieved without interrupting chest compressions. As soon as IV or IO access has been established, you're going to administer epinephrine, 1 to 10,000. It'll be 1 milligram of 1 to 10,000. That's 1 milligram per ml in a 1 to 10,000 solution, and it's administered IV or IO and can be repeated once every 3 to 5 minutes. Whenever you give a medication through a peripheral IV line during CPR, follow it immediately with a 20 cc flush. Then elevate the extremity for 1 to 2 minutes to facilitate the delivery of the medication. So you're going to push in your flush, elevate the extremity, Make sure that it's running into the body and do CPR for 2 minutes. That CPR is what circulates that medication to all the cells where it's necessary. The other thing that you need to make sure that you understand is that we not only are giving medications and doing CPR and doing everything that we can to manage this person in cardiac arrest, but I will challenge you that no matter what you do, if your patient is hypothermic, none of your medications will work. You have to remember, don't let your patient get cold. We still need to provide warmth. Still need to provide warmth. Now your saline that sits out in your trucks, it's generally kind of warm because it's out there in the trucks, so it will help. But we need to remember, you're stripping and clipping these people, taking a look and see if you see anything else. Cover them back up. Keep them warm. That's very important. Several options are available for airway management now that we've gotten to that point. A bag valve mask may be used throughout the resuscitation effort. For adults in cardiac arrest without an advanced airway, use a 30-to-2 compression to ventilation ratio. Ventilate with just enough volume to produce visible chest rise and deliver each breath over about 1 second. If the decision is made to insert an advanced airway, then verify placement by multiple methods, including waveform capnography, and secure the tube. After the tube has been secured, your breaths are going to be delivered 1 breath every 6 seconds or 10 breaths per minute without interrupting chest compressions. Chest compressions will then become continuous for a total period of 2 minutes. VFib or pulseless VTAC that persists or recurs after 1 or more shocks is called refractory VFib or VTAC. An antidysrhythmic such as amiodarone or lidocaine may be considered. Lidocaine is considered, amiodarone is considered, both have different dosages. We will talk about that more in the medication section of it, but the amiodarone dose for VFib is 300 milligrams in 50 cc's of D5W over 10 minutes. You can also put it in 100 if you choose to as well, but you need to run it over 10 minutes. The reason why, it causes a lot of thrombophlebitis. It'll eat up the veins. It's very caustic to the veins when you run it in too quickly. Lidocaine is 1 milligram per kilogram to 1.5 milligrams per kilogram, to a total of 3 milligrams per kilogram being administered. So, if you're given that, you know, your average dose is somewhere between 100 and 150 milligrams because of the way you're going to give it is IV push. It does not have to be diluted. Comes in a syringe. It's easy to inject, and then you follow it up with a drip, a prophylactic drip after the patient has achieved ROSC. During the arrest, consider H's and T's like we discussed to identify possible reverses causes of the arrest and factors that may complicate the resuscitation. Refer to table 17-5 in your book. If there at any point there is ROSC or return of spontaneous circulation, then assess the patient's vital signs, support the airway and breathing as required, and give medication as indicated for regulating the heart rate and controlling cardiac dysrhythmias as well as maintaining blood pressure. This table shows the causes and treatments of cardiac arrest rhythms to include also the H's and T's. This is table 17-5, and it's also slide 169 in the focus slides. So overall management, if local protocols allows, you want to begin transport when any of the following occurs. The patient regains a pulse. 6 or 9 shocks have been delivered or directed by local protocol. The device indicates 3 consecutive messages separated by 2 minutes of CPR, and no shock is advised. And again, you have to follow your protocol. Many protocols out there have what we call non-survivable cardiac arrest protocol. Otherwise, you will get to end of resuscitation, especially if the patient is in asystole. Special circumstances in cardiac arrest. Cardiac arrests that require the paramedic to adjust their treatments and procedures may include those associated with morbid obesity, anaphylaxis, opioid overdoses, acute asthma, and electrolyte disturbances. Post-cardiac care. So we're at the end and we've achieved ROSC. Begin by optimizing oxygenation and ventilation. If you have not started delivering high flow oxygen to this patient via an endotracheal tube or some advanced airway, and the patient is remaining unconscious with no gag reflex, make sure that you intubate them. Get them on high flow oxygen. If they by chance start breathing on their own, you need to maintain oxygenation at 94% or higher. Avoid hyperventilation. Hyperventilation is bad. We've discussed that in the respiratory chapter. Obtain a 12 lead as soon as possible to determine whether the patient has an acute ST segment elevation MI. Perform a neurological assessment and assess for signs of any hypoperfusion. Give patients a fluid bolus, 1 to 2 liters of normal saline or lactated ringer solution. If the patient has marked hypotension and the transport time to the medical facility is prolonged, then consider administering a vasopressor infusion such as dopamine or dobutamine, either one. If the patient is bradycardic or tachycardic, then follow the bradycardia or tachycardia algorithm. Start targeted temperature management after cardiac arrest for patients with ROSC or that have ROSC, that patients don't follow verbal commands or they remain unconscious. We're going to maintain constant target body temperature between 32 and 38 degrees for at least 24 hours. This is accomplished by a rapid infusion of cold IV fluids and was formerly recommended but is not any longer. As far as doing code ice or targeted temperature management in the field, it is not recommended any longer by the AHA. And most facilities and most medical directors follow through that for EMS. They don't do it out in the field. Closely monitor the patient's cardiac rhythm and get them to the nearest hospital as quick as possible. When to stop CPR. The American Heart Association recommends that rescuers that begin CPR will continue unless one of the following occurs. 1. Effective spontaneous circulation is restored. 2. Care is transferred to a team providing advanced life support. 3. The rescuer was unable to continue because of exhaustion, because environmental hazards are identified, or because continuing resuscitative efforts places other people in jeopardy. And then 4. Criteria indicating irreversible death have been met. Criteria of obvious death have been identified, or criteria for terminating resuscitation have been met. When a patient does not respond to pre-hospital cardiac care treatment, it is acceptable to cease efforts because ALS providers are capable of performing initial resuscitation equivalent to an in-hospital resuscitation attempt. There are no additional benefits to emergency department resuscitation. If your patient is dead, there is no benefit in taking them to the hospital. CPR performed during patient packaging and transport is much less effective than CPR administered at the scene. EMS providers are at risk for physical injury while attempting to perform CPR in a moving ambulance. Trust me, there have been a lot of accidents with people, first responders, paramedics, and EMTs and firefighters in the back of ambulances in which they've been hurt and even killed because they were working a code in the back of the ambulance. Continued resuscitation in futile cases places other motorists and pedestrians at risk. It also increased the amount of time during which EMS crew is unavailable for other calls. It impedes the emergency department care of other patients and it incurs unnecessary charges for the medical facility, and obviously that's passed down to the family. The AHA has published criteria for BLS and ALS termination of resuscitation for adult out-of-hospital cardiac arrest. In some jurisdictions, state legislation will be required to permit pronouncement of death at the scene by the paramedic. Gaining that permission to stop CPR in the field will involve delicate issues such as expectations of the patient's family, disposition of the body, pressure from bystanders, people freaking out because you're going to stop working on grandpa, or even worse, a son or a daughter. Okay? Paramedics unaccustomed to telling the family that a patient is dead is one of those things as well. There will come a time as a medic that you're going to have to tell some mother or some father that their child has died. It'll be one of the worst days of your life, one of those times that you're not going to forget. And you will have to do this. You will have to elect not to work CPR or work a code on an infant that has died sometime in the night, and you're called early morning hours to a baby that's laying in a crib that's blue and stiff. You will not work that infant. That is a sudden infant death syndrome patient, but you will have 2 other patients, the mother and the father. So with that said, we're going to go ahead and clock out of this one. We'll have some generalized discussion on cardiac arrest or the pulseless algorithm. We'll reconvene and we'll pick up at slide number 174 and talk with AV blocks. Thanks for joining us, and we'll see you on the next one. Be sure to clock out a virtual time clock.